Tonight's speaker is a doctor that really needs no introduction, but I'll give it a shot. Dr. Marguerite McDonald is a clinical professor of ophthalmology at New York University in Manhattan and adjunct clinical professor of ophthalmology at Tulane University Medical School in New Orleans. Dr. McDonald performed the first excimer laser treatment in 1988 and has received numerous awards for her pioneering work in refractive surgery. She was the first woman to be president for both the International Society of Refractive Surgery of the American Academy of Ophthalmology and the American Society of Cataract and Refractive Surgeons. Dr. McDonald serves on numerous editorial boards of clinical and scientific journals. She is an active member of multiple national and international professional societies, and she has over 1,500 publications, many of which related to tonight's topic of dry eye disease. On behalf of Oculus, I'd like to thank Dr. McDonald for being here tonight, and I'd like to thank everybody else here for attending. And without further delay, I will welcome Dr. Marguerite McDonald.
Thank you, Chris, and thank you all for spending part of your day with us. I'd like to review the pearls for success for starting a dry eye center of excellence. And I won't spend any time on how important it is to diagnose dry eye, how important it is for the health and welfare of our patients, for surgical outcomes. We all, for contact lens success, we all know how critical it is. So now we'll just sort of get into the nitty-gritty of how to get one started. So these are my financial disclosures. And first, when you get started, I think it's wise to identify a dry eye center of excellence that's already underway about 50 to 75 miles away from where you are practicing. Why? If you ask a colleague very close to you, they might be shy or reluctant to share what they know because you're a competitor. A colleague 50 to 75 miles away is not likely to be considered a competitor. You're not pulling from each other's catchment area. So they'll be much more willing to share everything they know. And you can get there in one day and come back with your practice manager and your chief technician. So you won't need the cost of airfare for yourself and your practice manager and the technician. You won't have to pay much by way of meals. You get there, you'll get back. They will get to have dinner with their family, which they will enjoy, and maybe all you need to do on the way is stop for a snack at Cracker Barrel. So it'll be a very efficient use of your time and very low cost. However, be considerate because having visitors will slow your colleague down significantly, rob him or her of any chance to answer email, talk to or text the spouse, and do any personal business. So ask if you can order lunch for the office from their favorite restaurant or deli. Ask in advance so that when you arrive at the door, everybody will be smiling. So observe your colleague with your chief technician while your office manager gets as much info as possible about billing, etc. And be sensitive because some practices will share everything but the financial information. And you know, some will say, this is when we started the Dry Eye Center of Excellence, this is what our expenses were, these are our profits, etc. Everybody should carry a notebook or an iPad or some way to take notes because you don't want to be calling back for weeks later. What was the name of that drug you used? What was the name of that device? How much did you pay for that instrument? Try to minimize that as much as possible. And if you need to go back a second time, if you've been considerate the first time, they will welcome you. So back at your office, start with a team meeting to let the staff know that this is important to you. They are not mind readers. You have to spell it out. This is important for the benefit of your patients. That is always your North Star. Whatever benefits the patients is most important, and everything else will fall into line after that. But as a matter of fact, it is really good for the health of your practice as well. And remember, rely on industry. The vendors all have implementation teams. They are eager to send somebody to your office to do an in-service, be up to speed, because they don't succeed unless we succeed. So rely on them. They have marketing materials. They have ready-to-go press releases to your local paper, everything you can imagine. Just ask. So now you're really going to get started. So the first way to launch this is to start with questionnaires and with TearOsmolarity. So there are quite a few validated dry eye questionnaires out there. We like the speed test, which actually came from TearScience. It gives you a lot of information. It's fast. The patients are not annoyed by it. It only takes them a few seconds to do it. Any positive finding on the questionnaire, redness, whatever, a burning, dry sensation, even one positive finding on the questionnaire allows your technician to proceed with osmolarity testing before you see the patient. And why do we say that? Because hyperosmolarity is the central core mechanism by which dry eye damages the ocular surface. There's some other practical reasons, practice management type reasons, but this is the easiest way to launch the Dry Eye Center of Excellence. Get your questionnaire going and start doing osmolarity testing. So it's objective. It certainly aids in the diagnosis of dry eye and helps you track response to treatment or non-compliance. It is really pretty easy to implement, and there's a relatively small capital investment. The handheld TearLab instruments are placed at no cost with you as long as you commit to a certain number of the disposable test cards. So, you know, that really is easy. And just a quick tip, we'll get into the science a little bit more, but a quick tip, don't let your technicians interpret the data. When you go to get a chest x-ray, if you ask the technician, the radiology technician, how does my chest x-ray look, they will never interpret it. They say the doctor will be here in a minute, we'll explain everything. Your tech should do that too, because otherwise they'll get lost in the weeds why one eye has a slightly different reading than the other eye, and you really don't want to spend the time on that. So I would also say, since they're being placed at no cost, put a unit in each exam lane. For every extra step your tech has to take, it will be used less. If it's right there, it'll be used all the time. And certainly, if you come in and you find somebody with dry eye at the slit lamp who didn't check off any symptoms, if the unit is sitting right there, it takes exactly 10 seconds to read both eyes. And I can't tell you how useful that is. So if somebody, because half of people with significant ocular surface disease, clinically significant, have no symptoms at all, that does happen. So you can just turn to the tech and say, let's get your osmolarity right this second. By the way, Inflammadry, which we'll talk about in a few minutes, is great for patients who've got symptoms that sound like dry eye, but their osmolarity testing indicates they don't have dry eye. So that means there's inflammation there, but it's not caused by dryness. Go back and take another look and see what you may have missed. So after everybody is comfortable with the questionnaires and osmolarity, then add Meibography and thermal pulsation therapy. And so now you're starting to get more sophisticated on diagnosis, and you're actually starting to offer an in-office treatment to them. So as you know, there are two Meibography systems. There's LipiView, which is part of the TearScience LipiFlow thermal pulsation therapy technology package, and the OCULUS Keratograph 5M, which has a wonderful placido-based topographer and 5 different ways to measure the tear film. So we'll go into the differences between these two. The first one is Meibography and a treatment package. The second is an incredible diagnostic package, and they both are great. Actually, we have one of each. We have a very, very big practice with almost 40 doctors, 3 of whom are optometrists, the rest are ophthalmologists, and we have almost 500 employees, so it's a huge practice. And of the 3 offices that I go to, one has the LipiFlow technology and the other has the OCULUS Keratograph 5M. But I will tell you that when you show a Meibography picture to your patients, you have them look up at the screen, and then you show them on a plastic-coated card that we have in each exam lane what their glands are supposed to look like. It's like a brick in the face. A picture is worth words. They get it. They understand that they have to comply with your treatment and perhaps consider some of the other therapies you're offering. So quickly, normal meibomian glands, They're vertical, there are no missing ones, they're not truncated, but abnormal Meibography. Once again, we'll spend a little more time on this later in the lecture. But you see there are some dropout, and they're truncated and inspissated and starting to become quite twisted. So now you are truly off to the races. You can add additional technologies as you see fit. An increasing number of extremely dry eye patients will seek you out. Before the Dry Eye Center of Excellence opened, even as a cornea specialist with a referral practice, I didn't see filaments that often. I'd see filaments 2 or 3 times a year. Now I see people with filaments almost every day because of the extreme dry eye patients that you will attract. Having said that, stock lots of punctal plugs and procerus limbs, which is the amniotic membrane suspended on a PMMA ring. More about that in a minute. And find a source for your desperately dry eyes to get autologous serum tears. So there is at least one large company in the U.S. that's planning to have regional weekend courses on how to start a dry eye center of excellence. So if you can't visit a colleague 50 to 75 miles away for whatever reason, maybe you're in a part of the country where there isn't a dry eye center of excellence at that distance, this will serve the same purpose, really, the regional weekend courses, and they should be announced probably in the fall. And once again, you have the advantage of going to these regional courses with your office manager and your technician, your chief tech, without having to put everybody up in a hotel and spend a lot of money on food and airfare. So now we're going to go through quickly every single diagnostic and therapeutic technology for ocular surface disease, just so you know what's out there. Now, some of them are a little more esoteric and aren't used as much as others, but I'll comment along the way. But by the end of the hour, you'll know every single thing that's on the market. And back for a moment to osmolarity. We'll start there. Hyperosmolarity really damages the ocular surface. As I mentioned, it's the central pathophysiologic mechanism for all forms of dry eye disease. It causes inflammation and apoptosis, which is programmed cell death, programmed cell suicide, leads to a breakdown of the homeostatic control causing tear film instability, and it also reduces the ability of the mucins to lubricate. It actually is very well established. There's 45 years of peer-reviewed research on tear osmolarity, and actually osmolarity was added to the definition of dry eye by several sources, including the Dews report and the American Academy of Ophthalmology. And it has the highest positive predictive value of any of the other classic dry eye tests, including Schirmer's tear breakup time, staining, and meniscus height. So the reason it's been around for so long without really being in common use is that it was a big, cumbersome machine that took a long time to process the samples. But now with TearLab, we have this very quick portable testing system. So you insert a test card into this little pen-like device, remove the cover, tilt the patient's chin up, they blink 3 times, and then you suck away 150 nanoliter sample from the lateral canthus, and you dock it in the TearLab unit and repeat it for the second eye. It is extremely fast. It really is a lab on a chip. It's got a CLIA waiver, so that's important in the United States to do in-office point-of-care testing, and you get your results very rapidly. So normal osmolarity, you see here on the far left, it's 295 to about 300. As you move into 305, 308, you've got mild dry eye, then moderate, and then severe, and the machine goes tilt at 400. So in the beginning, with mild dry eye, people have some compensatory mechanisms, blinking, which will increase lipid secretion. So they have some reserves to make up for the challenges of modern life, like air conditioning, forced air heating, wind outside, etc., computer use. But very quickly the reserves are exhausted. And so not only does the score go up in milliosmoles per liter, but the variability between the 2 eyes starts to go up. The average osmolarity has been shown to be 297 plus or minus 7 milliosmoles per liter. but a dry eye patient has an average of 323, plus or minus 17. The inner eye difference for a normal is only 6 plus or minus 6, but for a hyperosmolar dry eye patient, it's 17 plus or minus 16. Now, they've got a next generation platform coming, and this will have 1 or 2 additional markers, and very likely they will be focusing on inflammation. And they have a big pipeline. New iterations are possible twice a year. So up until now, with osmolarity, that is covered by insurance. But I want to pause for a moment to show you some data from Dr. Yu, who published in Cornea in 2011. So this data is already 5 years old, but it's still shocking. The average dry eye patient, moderate dry eye patient, spends $2,667 per year, and that's for their copays for medicine, their copays for doctor visits. It's higher than that now. As I said, this data is 5 years old, but it's death by 1,000 cuts. They don't realize how much they're spending. It's a copay for the doctor one day, then it's copay for their Restasis or whatever the next day, and then in 2 weeks they're buying a ton of preservative-free tears. So they don't realize how much they're spending. And I point that out because many of the things we offer now, at least in the United States, are not covered by insurance and are paid by the patient. So thermal pulsation therapy, we do a great deal of this at our Dry Eye Center of Excellence. Yesterday, I did 8. And this is a way to evacuate the altered meibum that's trapped in the meibomian glands. And there's 3 parts or components to this technology package. The interferometer you see on the far left, the meibomian gland evaluator, and the LipiFlow pulsation system. So the first 2 are diagnostic, the last is the treatment. Excuse me. So over the course of 12 minutes, the lids are warmed. 2 minutes into the 12-minute treatment, the altered meibum has been returned to a liquid state, as it should be, and then gentle pulsations from an air bladder cause the altered meibum to be expressed into the activators. Excuse me. Now that model, let me go back. The model is shown here with 1, but you're usually doing 2. Once in a blue moon, you'll get someone who is claustrophobic and you have to do 1 eye at a time. But the vast majority of people, if you have a technician in the room chatting with them, will gladly let you put both on so that both eyes can be treated during that 1 12-minute procedure. So this is just a close-up of the air bladders and the lid warmer, and nothing rests on the cornea. So you can assure the patients that it's really touching their eyelids, both sides of their eyelids, eyeballs. And this is just one data slide from the huge set of slides of data analyses that led to the FDA approval several years ago. It just shows that patients with blepharitis, and here you see baseline, very low total meibomian gland score. They went on daily warm compresses for 2 weeks and it did nothing. As soon as they were crossed over to a LipiFlow treatment, within 2 more weeks, their meibomian gland score, as graded by independent masked examiners, got much, much better, almost doubled within 2 weeks. Now, talked before about normal meibomian glands versus abnormal meibography. We're learning all sorts of interesting things. For instance, it appears that meibomian gland disease starts nasally and marches temporally. All sorts of things that we didn't know before without meibography. So we're going to move on for the moment to intense pulse light for meibomian gland disease. This is another treatment modality that you could consider offering. Rolando Toyos and Memphis designed the system probably about 10 years ago. And a xenon flash lamp, which is like a camera flash, very bright, very brief. This emits energy in a band from the base of the visible spectrum to the border between near and mid-infrared. And the flash lamp is filtered to allow just the right band of light to pass through, 500 to 800 nanometers. And the light is pulsed in milliseconds depending on the setting. So this has gained popularity in the US. I would say there's more people using LipiFlow than IPL, but it is quite popular. Meibo Thermoflow. This is usually done by the technician. It is a heat treatment. As you see here, the lids are warmed, and here's a high mag view. The upper and lower lids are treated simultaneously over the course of about 10 minutes. This shows people sitting upright, both the patient and the doctor. I don't have this system, but if I did have it, I would lay people down because I understand the technicians start to get very tired arms with their arms up in the air for 10 minutes straight. But it does work, and preliminary data indicates that the non-invasive tear film breakup time score improves from an average of 3 seconds after one Meibo treatment. It improves an average of 5 seconds after 2 treatments, and an average of 9 seconds after 3 or more treatments. So Dr. James Lewis is spearheading this effort, and he has some presentations and publications on the results. 75% of his patients elect a second treatment. 95% say Meibo alleviated symptoms. There's improvement in Schirmer test, tear breakup time, TearOsmolarity, the OSDI psychometric test, and the speed psychometric test. And statistically significant improvements were found in those parameters at 1, 2, and 4 months following a treatment. BluffX. We do a fair amount of this. BluffX is an exfoliative treatment. It's atraumatic. There's complete removal of the biofilm with this high-speed rotating soft brush. This debulks bacterial density, and it is, in the U.S., a private pay procedure, as are all the ones I've mentioned so far, except for TearOsmolarity. So here's a close-up view. This is a small unit. It can sit on any desktop. It is a rechargeable unit. It spins a disposable tip of microsponge 2,500 RPM along the lid margin. It completely cleans the lids. You repeat it every 4 to 6 months, and it is private pay, as I said. Actually, I've done a little more research since this slide was generated. The average, the low end is now about 200 nationwide, and the high end is 450, and it depends partially on what part of the United States you're in. If you're in a remote area like Fargo, North Dakota, and your technician is doing it, then it might be around 200. If you're in Manhattan or Los Angeles or a very high rent neighborhood and the doctor is doing it, it can be as high as 450, which is what they charge at Cornell in Manhattan. But it does work. And there have been presentations about this. There have been, now there's starting to be more publications in the peer-reviewed literature. In the most recent study, the tear film breakup time was significantly improved. The blepharitis, as judged on the Efron scale, significantly improved. Meibomian gland dysfunction drastically improved, and the symptoms on the OSDI were also much improved. So our practice has 2 units, and I do it, and my colleague Dr. Hank Perry and the other cornea service folks in our practice are getting interested as well. Eye Express, I don't have this, but it intrigues me. Dr. Ken Beckman is a dry eye leader in the U.S. who is a medical director and who is very enthusiastic about this. It's in-office treatment with heat. It's hands-free, but the patient does not take this home. The doctor does it, or the doctor's technician. It's a controlled electronic goggle-based system that heats the lids to 110 degrees. And it's non-invasive, and it's FDA cleared in the U.S. as a Class 1 device. And the results are impressive. Here you can see the non-invasive tear film breakup time, which we'll talk about in a moment, as judged by the Oculus Keratograph 5M. And you see horrifically quick tear breakup time, 3-4 seconds on the far left. And immediately after using a spray-on liposome spray, and we'll talk more about that in a minute, you can see that the tear film breakup time has been substantially improved to over 20 seconds. Procare Slim from BioTissue. This is a treatment for severe dry eye. And after your dry eye center of excellence, a few months in, starts to attract really desperate dry eye patients, these will come in very handy. Last year or the year before, I rarely put them in. Now, it's a rare day in the office where I don't put one in, and sometimes I put in 4 or 6. So what is it? It is an amniotic membrane that is suspended across a polymethyl methacrylate ring, and you pop it into eyes with severe dry eye. It can also be put on non-healing herpetic dendrites and a host of other ocular surface conditions, but it is FDA approved for the treatment of severe dry eye. You leave it in for 5 days, take it out. Usually we do one eye at a time because it does blur the vision a little bit. They have a new iteration of it that has a hole in the middle for the patient to see through, but still it blurs the vision. So it's one eye at a time. They come back after 5 days. You take out the ring. Often the amniotic membrane has completely dissolved, and you're left with an empty ring. You take that one out, and you pop it in a fresh one in the other eye for the next 5 days. And this buys the average severe dry eye patient months of comfort. Occasionally you get somebody who's so severely dry that you have to repeat it in a row, like 2 or 3 sets immediately in a row before you can get them to a point where they're going to enjoy weeks and months of comfort. I recently put 5 in a row on a severe hydrops case, a keratoconus patient with Down syndrome who was an intractable eye rubber, and he had a monster hydrops, the worst I've ever seen. I thought he was a poor risk for surgery. I was looking at a desmetocel, and I put 5 in a row on, and he's fine. We avoided surgery. Here's another view of a dry eye patient wearing a Procaris limb, and you know, that is something that comes in extremely handy, and it is reimbursed exceedingly well by insurance, at least at the moment in the United States. Now, MMP9, matrix metalloproteinase 9, that is a proteolytic enzyme that is produced by stressed epithelial cells. It is a non-specific inflammatory marker, and it can be used in some of the diagnostic dilemmas that we face, like when somebody has complaints that sound exactly like dry eye, but their tearosmolarity is normal. If you get a positive MMP9 test, that means this is an inflamed eye. Go back and figure out what you missed. So this can be done by a nurse or technician, and it's an in-office point-of-care immunoassay test. And it's really low cost. There's no additional equipment required. And the literature, we have many excellent papers documenting that the normal levels of MMP9 in the normal human with a healthy eye ranges from 3 to 41 nanograms per mil. So the test is set up to detect greater than or equal to 40 nanograms per mil. And here you see a positive result in an eye with inflammation has a blue and a red line. If you get just a blue line, that means enough material was sucked up into the cassette for it to be a valid test, but it's negative. So you get the assembled test here, and inside is the sample collector, the test cassette, and the buffer vial. Once again, this is a 10-minute operation here performed by your technician. So the tech gently dabs the sample collector along the inferior conge, snaps it into the test cassette, sucks up a little of the buffer, and then you read it in 10 minutes. This same technology platform has been used to detect adenovirus. So we're all familiar with this scenario and the corneal findings. So the RPS adenovirus assay, same cassette, same technology platform, is excellent in its sensitivity and specificity, right up there with cell culture. So once again, it's the same cassette with 90% sensitivity, 96% specificity. In the last published paper, it's CLIA waived. So if in the United States, if you have your lab CLIA certified, which is an easy thing to do, you can do this. So this technology platform is being expanded beyond the detection of MMP9 adenovirus. They're looking into allergy by measuring IgE, herpes simplex identification, chlamydia, etc. Now, the Keratograph 5M from OCULUS. I love this device. It's got so many different ways to help your practice I mentioned that there's an excellent placebo-based topography system, and it has 4 illumination systems depending on the task at hand, and we'll show the different things it can do. And before I leave this slide, you can see it's a tremendous help for contact lens fitting. And it has 3 magnification settings depending on the task at hand, either 9, 11, or 26 millimeters field of view. So how can you assess the tear film? There's the tear meniscus height measurement. So when patients have dry eyes, they don't always have a regular tear meniscus. There are clods of mucus, etc. So this analyzes it for you, or you can outline it and measure it. This is very popular, the non-invasive keratograph breakup time. For years, whenever there's been a clinical trial and the investigators have to estimate the tear film breakup time, even experts who devote their lives to cornea and anterior segment and dry eye are all over the place when it comes to their guesstimation of tear film breakup time. This is objective, it's repeatable, the dry eye is automatically classified, it's non-invasive and quick. It's a tremendous communication tool for the doctor talking to the patients, and you can document response to treatment. So here is a healthy young female who has a wonderful tear film with an excellent breakup time. So you have to throw a switch in your brain. This is not a topography map. This shows seconds of how long the tear film is remaining intact. So with this patient's lids held apart, there is greater than 24 seconds. The tear film never broke up during the entire 24-second exam period. So this is classified as level 0. It is not a dry eye. Here's a severe dry eye. So see, some of it is so distorted by dryness that it doesn't even digitize. That's where you see all the white here. But of the areas that were analyzed, you see that the tear film breakup is as low as 1.5 seconds in some places. So that has been classified automatically as well. This is another example. If you use, this happens to be a spray available in Germany called LipoNit, though we do have one in the US, TearScan liposome spray. Before use and 10 minutes after use, you see how the addition of liposomes containing fat has allowed stabilization of the tear film by adding lipid and preventing or treating evaporative dry eye disease. There is another way to analyze the tear film called lipid layer assessment. We know that the thicker the layer of lipid, the more colors you see. So this shows that the spectrum colors that are reflected are a direct indication of thickness. So up until now, if you had no instrumentation, you could try to figure out how thick the lipid layer was by looking for this tiny little reflection that appears at 3 or 9 o'clock just on either side of the slit beam. And it's only about 0.5 by 0.5 millimeters, and it's really hard, but you can get a little bit of a hint as to what the colors are. And a few years ago, the Keeler TearScope was developed, and this was definitely a step forward because you get a 4 millimeter visible area. But if you could have an even bigger area, that would be ideal, and that's what the OCULUS Keratograph 5M gives you. It gives you a 9 millimeter field of view, vastly superior to slit lamp observation and the Keeler TearScope. So thick lipid layers have lots of colors, like you see here. Thin lipid layers are all grayed out, and that can be quantified. Now, this is fascinating, tear film particle movement. There are little bits of debris in the tear film that we all kind of ignore. Some of it is broken cilia, dried mucus, a little bit of makeup in the women, but we ignore it. As it turns out, the speed and direction with which the particles are flying are a direct assessment of the tear film viscosity. So small bits of debris are identified and tracked. And this is the only machine that I know that does it. So I mentioned the Meibography of the eyelids. I think this is incredibly powerful, very powerful. So you have to avert the lids if you want to look at the upper lids, but I find that some technicians are comfortable doing this, some are not. And I found that if you just ask the technicians to pull down the lower lid, you'll get enough information, because what's going on in the lower lid is going on in the upper lid as well. This is where you use the largest working distance of the Kerograph 5M. And so you get this 24mm view, and you can see the whole upper and lower tarsal plates and the structure of the meibomian gland. So infrared LEDs are used to illuminate the lid to see the meibomian glands. And the meibomian glands are manually marked for digital image processing. And you get this calculated 3D representation of the meibomian glands. So as I mentioned, we're learning things we didn't know before, that the dropout seems to start nasally and march temporally. Fascinating new information. Now the R-scan. R-scan is wonderful. It's the automatic detection of bulbar redness. So this is another area where the experts disagree. You can have 20 experts sit down and look at an eye, and somebody will say there's 1+ conjunctival erythema, somebody else will say 2+, and you get a few people who say 3+, all experts. So here you see the image of the eye with the Kerograph 5M. There's digital image processing by the R-scan software, so there's automatic detection of the sclera and detection of the vessels in this black and white representation. So the ratio between vessels and conj is calculated, and a normal healthy human eye has about a 16% vessel to conj ratio. This is grading based on the ratio of the vessels to the conj, and it goes from grade 0 to grade 4. Grade 0 is found only in children and cadavers. Grade 1 to 2 is normal, and grade 3 and 4 are clearly signs of pathology. So you can isolate just the limbus if you wish. So if you're following a case of uveitis, iritis, the ciliary flush can be measured automatically and graded. Now, there's something called the JENVIS dry eye report. So all of the tests are shown here in a spider plot. So this is an empty, a blank JENVIS dry eye report. So here you see each one of the tests is shown in the spider plot here, connected by the blue line, and the exact score the patient had for each test is shown here with the little blue dots. Green normal, all the way up to red abnormal. So in a flash, you can see all the tests for both eyes instantaneously, and these blue lines can help you with pattern recognition. So this just shows a printout. Now, Tomey does have a tear stability analysis system. We do not have this. This is relatively new. It is possible to do spectral domain testing of the tear film with an OCT. And you see a regular epithelium and a normal tear film on the left, and a dry eye subject on the right with irregular epithelium. I must say we don't do that. We have the technology to do it, but that seems to be done almost entirely during clinical trials. Now, when you get really fancy, if you want to, you can start doing conjunctival cell harvesting to look for biomarkers. We don't do this either. This is almost entirely at a university practice, but iPrim is a new device that allows you to do it very quickly and without even dropping an anesthetic. And not only is it fast, you end up collecting twice as many cells as with the time-consuming, somewhat painful method of the past. So there's a 40% reduction in sampling time, and you get twice as many cells. So if you're interested in flow cytometry or PCR, this is an invaluable tool. Now, serum testing for biomarkers of Sjogren's syndrome. We do a lot of this. In the US, you do not get reimbursed for this test, but you have the opportunity to change your patients' lives and even save some of them. So there are new proprietary serum tests that are far superior to the older tests that have been around for 40 years. The old tests have a specificity of only 40 to 60%. They don't detect early stages of the disease. And these early new biomarkers will appear 4 years before the standard biomarkers turn positive. So the novel early biomarkers that have been identified are salivary protein 1, carbonic anhydrase, and parotid secretory protein. They're expressed far earlier in the disease, and these tests have a higher specificity and sensitivity. And this is our chance to catch patients earlier in the disease, prevent the xerostomia, the dry mouth that leads to bad breath and to horrific caries, pulmonary fibrosis, and even lymphoma. More about that in a moment. So all the new tests and all the old tests are done on the show test panel. And we started doing this with drawing blood and finger sticks, but everybody has quickly abandoned that. You just hand a slip to your patients and they go to LabCorp or Quest or another laboratory. And you get the results usually in about 2 weeks. But it's important to do this test because about 10% of dry eye patients have Sjogren's. The average time to diagnosis is about 10 years. They have miserable lives. Many, many of their organs are impacted. And besides the dry nose, dry mouth, nosebleeds, the dry eyes in women, the dry vaginal issues, in addition to all of that, and the thyroid issues, and the constipation or diarrhea, and the Raynaud's phenomenon, there's actually a huge increase in the risk of non-Hodgkin's lymphoma. It's 19 times greater than in the general population, which means that 5 to 10% of the Sjogren's patients are going to get it. If you catch it early, it's 100% curable. If you catch it late, it's not. So if you get one of these tests back positive, everybody on the patient's medical team should be informed. The dentist, the internist for sure, to keep screening for non-Hodgkin's lymphoma. And there's 1.54 more deaths per 1,000 person years. I find that a difficult number to absorb, but it's just easier to remember that there's 19 times greater risk of death from non-Hodgkin's lymphoma. So the overwhelming majority of these patients are female. Only 1 in 10 of the Sjogren's patients is male. However, when the men get it, they're quite sick. The biomarkers for Sjogren's syndrome are significantly decreased in men, which makes it harder to diagnose. But men with Sjogren's have a 3 times higher risk of mortality than the female patients, so it's important to catch them. Now, ocular allergy testing, I would recommend adding that not too far into the dry eye center of excellence development. Right after you start Meibography and some of the tests I showed you with the OCULUS 5M and thermal pulsation therapy, ocular allergy testing fits right into an ocular surface disease center of excellence, which is how we recently renamed it. In the United States, at least, it is covered by almost all of the major medical insurance programs and certainly by Medicare. The region of the United States is actually divided now into 39 separate antigen panels, and it's FDA approved. It's non-invasive. There's no shots, no needles. A tech does it. Takes about 2 minutes for the tech to do the test, and the results are read in 10 minutes. And then they bring the patient into the exam lane, and I spend exactly 1 minute telling the patient what they're allergic to and giving them some information on how to avoid those allergens. And we put a little cortisone cream on them before they leave the office, and it's been wonderful. So patients learn what to avoid. They're always surprised and grateful. Some of them find out that they're allergic to the plants that are growing on their kitchen windowsill for the last 20 years. It's very, very, very informative. Now, TearScan microassay system is a point-of-care testing for lactoferrin and IgE. Lactoferrin is a glycoprotein with a molecular weight of 70 to 80 kilodaltons. It's found in milk, tears, synovial fluid, neutrophilic granules. It has anti-infective, anti-inflammatory, and immune stimulatory functions. I'm going to pick up speed to make sure we have time for questions and answers. So there are about 1,500 proteins in the tears, and lactoferrin makes up 21% of that total tear protein. Lactoferrin is produced in the main lacrimal gland and also the accessory lacrimal glands of Wolfram and Krauss. And it has tremendous sensitivity and specificity. and it has been adapted for testing for ocular allergy as well, and it picks up tear IgE levels. And the sensitivity and specificity of that point-of-care test is excellent also. So no matter what you're testing for, you suck it up into this tiny little micropipette from the lateral canthus, much like the way you do an osmolarity sampling. You pop it into the system, and you get your answer very quickly with a printout. We do not have this system, but I'm interested in getting it, especially if there's any delay in the development of the allergy testing with the TearScan system that we already have. So we know what the lactoferrin levels should be, and if they're low, that's an indicator of dry eye disease. And we know the levels for IgE. Many peer-reviewed papers, high IgE documents the presence of an allergy. Now, most people start to get into a product line expansion. They start offering masks, lid scrubs, nutritionals in their office. One of the more popular masks is the Bruder Mask, which can be used over and over again. It's microwavable for 20 to 30 seconds, and it gives a wonderful 10 to 15 minutes of heat. Very, very helpful for patients. For people who travel a lot or who don't want to traipse downstairs to the kitchen to use the microwave at the end of a long day, there is the hygiene mask, which is really great because there are pockets into which you slip these little InstaWarmth warming units. So you tear open a warming unit. The minute air hits it, it starts to warm up. You slip it into the pockets in this mask, and you get 10 minutes of wonderful heat at exactly the right temperature. So my patients who travel a lot or who just don't want to go downstairs at the end of a long day use this mask. This is the one I use. So I mentioned that scrubs are a product line expansion. OcuSoft, Avenova, Claridex, there were many others. And you know, it's good as you expand to offer those. And we've started in one of our offices to offer them, and they've been a big hit. A lot of patients, especially if you say, listen, we're pricing this the same as a Costco, they will just, for the sake of speed and convenience, buy it from your office. Omega-3s, many doctors, ophthalmologists and optometrists sell omega-3s. There was a classic study by John Shepard and a more recent one by Eric Donenfeld showing that they do work, and very quickly. This is one of the original papers by Shepard from 2013. This shows that the ocular surface disease index with nutritional supplementation with omega-3s was incredibly improved in the treatment group over 6 months. And so the patients are way happier. Their HLA-DR staining of their conjunctiva and cornea vastly improved. So is their CD11C staining, another marker for inflammation, vastly improved. And this was an Arbo presentation. He happened to be using Hydro Eye from Science-Based Health, but there are many excellent omega-3 formulations out there. Very quickly, collagen, prolong, silicone, hypercator, there are many ways to close off the puncti. Punctal plugs can be placed in the lower and upper puncti to prevent escape of the tears into the canaliculi. And some are designed to dissolve over time, and others are designed to be more permanent, though all of them can be removed if necessary. The two basic designs for permanent plugs, we all know, intracanaliculaire, my favorite, and the classic collar button. So punctal plugs are so good now, I can't remember the last time we had to close puncti with cautery. And they also provide a promising drug delivery platform. Ocular Therapeutics is looking to deliver long-term glaucoma medication that way. So one last word. The reason I like intracanalicular is that the classic collar button plugs sometimes dislodge and start scraping the cornea, and they can make people very uncomfortable and even give them abrasions. The intracanalicular just never do that. And there's a brand that I like, no financial interest at all, but Oasis Medical Form-Fit plugs have never been associated with canaliculitis or dacryocysto-rhinitis. And if they have to be flushed out, it's easy to do so. They shatter quietly and painlessly into hundreds of little pieces. If irrigate the punctum with saline, and they will come out the next time the patient blows their nose. And they're in such tiny pieces they won't even. Lacrossert from Bausch & Lomb has been around forever, and it does work wonders for a subset of severe dry eye patients. It's a sterile, translucent, rod-shaped, water-soluble rod. It's preservative-free. You tuck it into the inferior cul-de-sac, and it releases continuous lubrication for 1 to 2 days. Coming soon, Ocular from Allergan for nasal stimulation of tears, and Lifitegrast as a topical treatment for dry eye disease from Shire. They're coming very soon. Ocular is a non-invasive nasal neurostimulation device. The results from 4 clinical trials are amazing, and we think it will be launched end of 2016 or 2017. And Lifitegrast from Shire is a small molecule integrin antagonist that blocks the binding of cell adhesion molecule ICAM1 to the T cell surface. So it inhibits T cell recruitment, activation, and cytokine release. And the results, once again, were extraordinary. And we expect the FDA will approve it this July 22nd. And then it will take weeks or months to get into the drugstores. But it works in a different way than Restasis. It has very quick onset of action. Results are seen as early as 2 weeks into treatment. And I think there will be many severe dry eye patients that are on Restasis and Lifitegrast both. So the bottom line, it's good medicine to treat dry eye, and we have better diagnostic technologies and treatments than ever before, which leads to happier patients and better surgical outcomes, and certainly it helps the bottom line of your practice. So thank you for your attention.